morning, guys. So we're going to just have a look at chest X-ray interpretation today. Okay, we're just going to go through a bit of a systematic approach of how we look at chest X-rays and interpret them. I'd be really keen if you can ask questions, and we get quite interactive as well. So just going to go through the objectives. So the objectives of the session today are to develop a systematic approach and problem solving to chest X-ray interpretation, to be able to identify anatomical landmarks on a normal chest X-ray, to be able to identify abnormalities on the chest X-ray, and to recognise chest X-ray appearances of common pathologies, and then look at an appropriate treatment plan. And what I've also done is, because we're doing a little bite-sized session, what I've done is I've got some work for you to do when we've left this session to consolidate your knowledge, and then we're going to come back together next week and go through that work, just so we can make sure we've consolidated that knowledge. And again, you can ask any more questions that you might have. Okay. Has anyone got any questions to start with? No?
Not yet.
Are we all? Has anyone been able to interpret chest X-rays before, or is it something that you've covered at university?
Very briefly. Yeah, very briefly. I've seen a few, but I've not been able to identify much myself.
Yeah, and they didn't go through the approach of looking at chest X-rays at university at all?
Yeah, we went through it
You
in
did?
terms of the different stages. I think I've found where I've been able to identify a few things, but then putting it all together has kind of been the bit that I might benefit from this from. So.
Lovely. All right, so let's look at the normal anatomy. So that is a normal chest X-ray. Everyone happy with that? Yeah. What can you see on that chest X-ray? Shout out. Tell me what you can see.
Heart borders.
Heart borders, yeah.
Diaphragm.
Yeah.
Ribs.
Excellent. Anything else?
Clavicles.
Clavicles. Fab. Okay. What we're going to do is just have a look at the little diagram. So you've got your trachea. So you know the airway down there, and then that branches out into your bronchus there. Okay. You've also got this little notch here. Can you see that little notch that goes around here? You might have to come a little bit closer. Do anyone know what that is?
Is it the aortic arch?
Yep, the aortic arch, fab. So that's your aortic arch there, okay? And then obviously you've got your heart, okay, your diaphragm. Does anyone know what this angle is at the bottom? Costophrenic angle, fab, okay? And what about this angle between your diaphragm and your heart border? Cardiophrenic, excellent, fabulous, okay? And then we've obviously got the little airways which we can't see, okay? So that is a normal chest X-ray. When you look at that, does that look normal to you?
Yeah.
Yeah, fabulous. Okay, so the fact that we can know what a normal is and what looks normal helps us when we're obviously looking for abnormal. Okay. So, again, this is just highlighting the areas actually on the chest X-ray so you can see. So it's highlighting your costo and cardiophrenic angles, your right hemidiaphragm and your left hemidiaphragm, your right atrium and your left atrium of your heart, your aortic arch, and your trachea. And then you can also see your spinous processes through your trachea, and that tells you that you've got good imaging on your chest X-ray. Okay. So, first things first, when we're looking at chest X-rays, we need to make sure we've got the right chest X-ray for the right person, the right date. With the systems we use in hospital at the moment, someone could have 6, 7, 8, 20 different chest X-rays, and it's very easy to mix up or not look at the right one. So we need to check the name on the chest X-ray, the date that the chest X-ray was performed, and the time. So if we've got patients that are deteriorating on the ward, they could have had 2 or 3 chest X-rays in the space of 48 hours. So we need to make sure we've got the most up-to-date one. Okay, and also the position that they're in on the chest X-ray. Are they stood? Are they laid? Are they sat? Okay, so it's really important that before we do anything else, we check all the demographics on that chest X-ray. Okay, and then we have to look at orientation. So they use the acronym RIPE to make sure that we've got the right orientation. So R is it rotated? So you can look at the medial part of the clavicles to make sure they're equidistant, to see whether the chest X-ray is rotated or not. Inspiration, we can look at how well the patient breathed in. So if a patient's walking in as an outpatient to have a chest X-ray done as a routine thing, they will be stood and they can follow instructions and they can take really deep breaths. if you've got a patient that's deteriorated on the ward and they're really struggling with the breathing, they are going to struggle to take deep breaths, okay? But what we do have to look at is, you know, have they taken a good deep breath when they've had that chest x-ray taken? P projection, has it been done AP or PA? So a lot of the patients on the wards, they'll be done AP because they'll be sat or laid in bed, and so they'll be done anterior to posterior. If you're coming in as an outpatient and you're having a chest x-ray done like that, then they're quite mobile, and they'll be able to do the chest x-ray posterior to anterior. Okay, and then we also need to look at the exposure. Is it underexposed or overexposed? Okay, so we've got a bit of an analogy is probably, I think it's the right word. You know, if it's underexposed, it's too white, and if it's overexposed, it's too dark. So think about toast. So if a toast's underdone, it's white. If a toast is overdone, it's burnt. It's, you know, it's dark. It's white. So that's like the way we try and remember it. So we need to also look and make sure we can see the vertebral bodies through the heart shadow. Will that tell you if we've got a good exposure? And you'll be able to see 10 ribs posteriorly on a inspiratory film. That is if the chest x-ray has been taken at a good angle, and it's a good chest x-ray that's been taken. Sometimes if patients are in funny positions, you're not always getting a really good, clear chest x-ray. Okay. And then we use a systematic approach. And every time we look at chest x-ray, if we go through this systematic approach, it does make it easier, and we tend then not to miss things, okay? So it's A, B, C, D, E. So I think everything we do at the moment seems to be A to E approach. So it's just another one of those. So you've got your A, you've got your alignment, your airway. B is your breathing. C is cardiac, so your heart. D is your diaphragm, and then E is everything else. Okay. Has anyone heard of that approach? Is that what they discussed at university? Yeah. Fab. Okay. So airway. So your trachea. We're looking at, is it central? Is it central on the chest X-ray, or is it deviated to one side or another? Okay. And then just to note that actually it does deviate slightly as it passes the aortic arch. So is it deviated because of the aortic arch, or is it deviated because there's something like a pneumothorax or atelectasis at the bit of lung collapse? Okay. You should be able to see where the main bronchi are and how they separate, and the carina. You can't see the small airways unless it's on a bronchogram, but you can see marks on the chest X-ray, which is like the blood vessels where the small airways are. Okay. So if you've got a trachea that's slightly deviated, do you know how you can tell what that deviation is? Anyone got any idea? No? Okay. So if you've got if your trachea is slightly deviated, there's usually two reasons for that. They've either got a pneumothorax or they've got a lung collapse. Okay. So if your trachea is deviated to one side, it's looking at, is that because there is a pneumothorax on one side, and we all know what a pneumothorax is? Yep. So if you've got a pneumothorax and the air's escaped from the lung and it's trapped in the pleural cavity, it'll push, and it'll push, so that pleural cavity space will increase with air, the lung will get squished and it'll push it all over to the other side. So you've got your pneumothorax, say, on your right hand side, and the air's getting trapped, and so it's pushing everything over, so it'll deviate your trachea to the left. Does that make sense?
Yeah.
Is everyone happy with that?
Yeah.
If you've got atelectasis, if you've got collapse, so say we then have a collapse on this side, because that top lung has collapsed, and it's because we breathe with negative pressure, as that collapses, it pulls the trachea over to it. So if you've got a deviated trachea, you need to look for whether there's a collapse and it's pulled that trachea over, or whether there's air trapped and it's pushing the trachea to the other side. Is everyone happy with that? Yeah, happy with that. And that makes sense?
Yeah.
Is it
Lovely.
Is it other factors that you'd look at to see if it's a push or a pull? I know that might sound like a silly question, but
Yeah, so even if your trachea is deviated, you would still go through the A to E approach.
Yeah.
And look at things like, is the lung markings towards the edge of the lung field and things like that, which would also indicate whether it is a collapse or a pneumothorax, but we'll go through that.
lovely.
Okay. So then your B is your breathing. So we're looking at your lung zones, we're looking at is it normal translucency in the lung field, and is it symmetrical? In theory it should be symmetrical, so if it's not, there's something going on there, so then we need to look a little bit further. And also your lung markings should extend all the way to the edge of your lungs, and this is where it would highlight if there's a pneumothorax or a collapse, because you wouldn't get the lung markings all the way to the edge of the ribs. There would be black space, you know, or consolidation. So yeah, so it's looking at that. And then also we'll just look at the pleura for abnormalities. So you should not be able to see your pleura on a chest x-ray. If you can, then there might be something wrong, and that could be something like cancer, mesothelioma, a tumour. So it's just being aware that actually if you can see the pleura, we need to just investigate that a little bit further. Okay. Yeah? Well, that is a good question. It's just like a white thickening at the edge of the lung that's not the ribs. Okay. I'll for the next session next week when we're consolidating everything, I'll find some examples so you can see. I think I've got one saved, an example of a gentleman that you could see the pleura of, and actually he had a tumour there that had been missed because no one had looked at that part of the chest x-ray. Okay. Cardiac, so your heart. So it should be less than 50% of the total thoracic window. Okay. Does anyone know if the heart is bigger, what that's called? So if you've got a really big heart, do you know what that might be called?
Hypertrophy, not hypertrophy, something like that though.
Cardiomegaly?
Oh.
Has anyone heard of that?
No, I've never
So an enlarged heart. So again, I've got some examples of showing you an enlarged heart. So it's, you know, we're looking at the heart, we're looking at it's not taking up more than 50% of the thoracic window. We're also looking at it's in the right position. So again, if we go back to thinking about your pneumothoraxes or your atelectasis and collapse, if something is pushing or pulling the lung, it will also move the heart as well. So we're just making sure that it is in the position it should be. So it should lie a third to the right hand side and 2/3 to the left hand side in a PA film. Okay. And then your D is your diaphragm. So each hemidiaphragm should be dome shaped, and they should be pretty much level. The right is literally 1 or 2 centimetres higher. Does anyone know why the right side of the hemidiaphragm is higher? Yeah, excellent. The liver pushes it up. So it's just making sure that, you know, one's not excessively higher than the other. Also, sometimes they can show higher if they've got like a bowel obstruction or they've got a distended abdomen. That can also push upon your diaphragm as well, so it's just to consider that. But we're looking at the diaphragm, we're making sure that they're pretty level, and also we're looking at the cardio and costophrenic angles. In a normal chest x-ray, those angles should be clearly defined, you should be able to see them. If you can't see them, something's going on, whether that's an infection, a bit of pleural infusion, something like that. So again, as you go through that approach, if you pick things up, it's just then looking in a little bit more detail just to see what else might be going on. Everyone happy with that? So we've got airways, we've got your breathing, we've got your cardiac, we've got your diaphragm, and then we've got E, which is everything else. So what might come under E? What might you have as everything else? What might we want to also look at? Yeah, attachments, gadgets. So what might show up on a chest x-ray? Pacemaker, yeah. Your oxygen tubing, if you're on intensive care or on the surgical ward, an NG tube would also show up on a chest x-ray. Okay. What else might you look out for on a chest x-ray? If you think of maybe some trauma patients, yeah, rib fractures. Okay, and then other things that you might want to look at. If you're looking at the soft tissues, what might you find in the soft tissues on a chest x-ray? You may not have covered this, so don't worry if you're not.
Like tumours, is that?
You potentially could, yeah. Has anyone heard of surgical emphysema? Yeah. So surgical emphysema is air trapped under the skin, and it feels a bit like bubble wrap. And you know, once you've felt it, you'll know. You touch it and it crackles, and it's like bubble wrap under your fingers. So again, we've got some examples of surgical emphysema, but actually, you know, under the skin there shouldn't be any air, so if there is air showing, it's easily visible on the chest x-ray to have a look at. Everyone happy with that A to E approach?
Yeah.
Okay.
Sorry, Rich, can I just ask, pneumothorax and hemothorax, how do they differentiate in there?
So your pneumothorax is just air, your hemothorax has got some blood in, but they would tend to show very similar. You would have a black space on your chest x-ray with no lung markings, and you would have a deviated trachea, and therefore you may, on a hemothorax, if there is a collection of blood, get a little bit of white at the bottom where sort of the blood's collecting, depending on the position they're in. But on the whole, it would be a black area on your chest x-ray. Okay. Again, we'll go through some of the common pathologies. So you go through your normal A to E approach, okay, and that is, you can do that for a normal chest x-ray. But when you are going through that approach and you pick something up like a blunting of an angle or a deviation of your trachea, then that's when we're thinking about what sort of pathology could that be. Okay. So we'll just have a look at some common pathologies. So, what does everyone think about that? You can come a little bit closer if you can't see. I know it's difficult on the screen. Does that look normal?
No.
No. So should we do the A to E approach? Yeah. Okay, so what do we think about the airway?
Deviated trachea to the right. Is it?
Yeah.
Yeah.
Yeah, you can see that. So the one thing that we can't do on this is look at demographics, because obviously we're not allowed the patient information. So we would have looked at demographics first, but it does tell you here that that is the left-hand side and that is the right-hand side. And that's common on a chest x-ray. You've got to remember when we're looking at it that it's opposite to, you know, when we're looking normally. So yeah, the left-hand side. So yeah, you've got that deviated trachea. Okay, so that's your airway done. B, your inspiration, your breathing, your lung fields.
I would say that the right hand side, even though it's not as clear because it's quite white, it does also look like the right lung doesn't look as inflated compared to the left.
Yeah, exactly. So remember we talked about that symmetry. Okay, can you see here? You've got you've got your ribs going around, but actually here that's not symmetrical, is it? It's very much, I suppose you would say it's deflated. It's not the elevated and horizontal. It's very deflated. Can everyone see that? It's very difficult to see the ribs here, but this is very more clear that your first rib up here is actually angled further down there. Can you see that? Yep. So, and also if we think about lung fields in that respect, what do you think to that lung field?
It's not clear.
You can't see it, can you? You can't see the lung field. Okay, so yeah, so we already know that the trachea is deviated, so something's going on. We've looked at the breathing, we've not got the equal inflation on both sides, and we've not got a clear lung field. Okay, and then C, cardiac. Think about cardiac, what do we think about the heart?
You've not got clear borders.
You've not got clear borders. If we're thinking this is the centre,
See it much on the left.
you can't see it at all, can you? Well, you can't see it on the right, and then it's less on the left. Does anyone think it might have shifted at all? What do you think? There could be a little bit of shift that way, couldn't there? Okay. So again, we know something's not right with this chest.
Is that the heart where it's 2/3 on the left and then a third on to the right?
The heart should be 2/3
okay.
onto the left. I don't think it's 2/3 onto the left now. But we know something's going on. We've got a deviated trachea, we've not got clear lung fields, we've not got equal expansion, and we've got potentially a bit of a shift of the heart. Okay. Diaphragm. Take a look at the diaphragms.
It's a lot higher on the
Quite flattened on the right, on the left. It's not.
Yeah, so that means potentially that's because he's taken a breath in, hasn't it? So as you take your breath in, your diaphragm moves down. So potentially that might be quite flat. But I mean, we can see here? What can we see here? We can see we can see that angle. Yeah. And we can see a bit of the angle there. But what can we see on the right?
You can see a tiny little bit of the angle, it's not very clear. Is that in the corner?
We can't really see anything here, can we? It's just all white. Okay. So we can't clearly see the diaphragms and we can't clearly see all the angles. So E, anything else? So what were we thinking about anything else? We were thinking about the bones, if there was any fractures, weren't we? So with the bones, the best way is to follow the bones round. Yeah. And you'll be able to see if there's any fractures or not. What we can't do is we can't follow them round on the left, we can't see them properly.
Would you say the X-rays underexposed?
Potentially yes, a little underexposed. You can't see the spinous processes all the way down. You can't see them through the heart. So yeah, a little bit underexposed, and that might be a reason again why we can't see all the ribs. But also it can be affected by obviously what's going on this right hand side. So we've got a deviated trachea. Okay, we've got unclear lung field, so the lung field's not clear. We can't see the diaphragm and the heart shifted slightly. So does anyone have an idea of what this could be?
Collapse.
Yeah, fabulous, a collapse. So what's happened here is something's happened, so it could have been, I mean, there's many reasons for a collapse. It could be a mucus plug that's blocked the airway and the lungs collapsed. It could be you know, a severe pneumonia. But what's happened is that the lungs collapsed, and as the lungs collapsed, it's drawn everything across, okay? So as that lung collapses, it draws everything across, okay? And obviously it's white, and it's white because we're not getting what in it?
Yeah.
Air. Okay. Any questions? Is everyone happy with that? Okay.
Yeah.
The thing with chest x-rays is, there is a systematic process and we go through that process, but sometimes some things aren't as obvious, so it's all about practice and just going through that approach every time, and then asking, if you're not sure, asking, you know, that question. And it's not something that you always get straight away. You just need to consolidate that knowledge and that experience, and then you will, you know, be able to pick up things a little bit easier. So yeah, so collapse anaphylactis, so there's a loss of air, okay, which is the white areas. The diaphragm could be raised, but it was very difficult to see because it was white. And there was, in the upper lobe collapse, the trachea is deviated, and in the lower lobe, the heart's deviated. So if it's a full collapse, it's both deviated, okay? And it's towards the area of collapse. So if you just think, it sucks it all across, because there's no air in it, it just sucks it all across.
Can I ask you a question?
Yeah.
You know, if you've say just got a lower lobe collapse,
Yeah.
would that look the same, or would you be able to see that it is just a lower portion of the lobe? Do you get what I mean?
Yeah, so if there's a lower lobe collapse, there will still be air getting to where?
The upper.
The upper lobes. And if there's air in the upper lobes, what would that show on x-ray?
You get the block.
You get the black.
Right, okay.
Yeah.
Yeah.
So if it is just one lobe collapse, you would still get air in the other lobes, and that would show up on the x-ray.
And you just see it's like the white within that portion that's
Yeah,
collapsed, right?
but you'd still see some deviation.
You would, right, okay.
What does everyone think about this one? I know it's difficult for you to see, Jade, though, isn't it? I'll send the presentation to you all as well, so you can have a look in your own time at these x-rays as well. Again, what do we need to do with this x-ray? We need to go through what?
A to E.
A to E. So someone wants to start off in the A part?
Pretty central.
Yeah, so it's pretty central, isn't it? So we're happy with the airway, so let's move on to B, the breathing. What do we think? We'll look at the ribs.
It looks relatively equal. It's a bit more difficult because it looks like the body's at a bit of an angle.
Yeah, it is. It definitely is. You can see there it's semi-erect and it's immobile, so this patient will have been quite poorly when this was done. Yeah, so they look quite equal, don't they?
Yeah.
So can we see lung markings to the edge of the lungs, the edge of the lung field? So when we're talking about lung markings, it's all these little white bits. These are like the blood vessels. Can you see it? Are they going all the way to the edge? I mean, it's very difficult to see because it's slightly chopped off there, but is the lungs going all the way to the edge?
Yeah.
Yeah. Yeah. So airway's okay. We've got equal it's symmetry on the lung fields in terms of the rib angles. We've got markings to the edge of the lungs, but what can we see in that? What can you see in those lung fields? What's staring out at you?
Not white patchy parts.
So this white patch here. Okay. Anyone have an idea of what that could be?
Consolidation?
Yeah, consolidation. So that's, you know, pneumonia, consolidation. The air's not getting into that specific zone. So that's a mid zone, isn't it, on the right? It's not getting into that zone of the lung. Okay. So again, as you were discussing from a collapse point of view, you know, this zone, it's not collapse, it's mid zone, but there's consolidation there. But we are still getting air up, and we are still getting a bit of air down there. Okay. So yeah. So then cardiac, let's just have a quick look at the cardiac. What do we think about that heart?
Looks a little bit enlarged.
Yeah, it does. And what else? What if we're thinking about the distance on the left and right? What do we think?
Shifted towards the left side.
Yeah, we can't quite see it on this right. Now, what potential reason could that be? If you're thinking about the orientation of the chest X-ray,
They might be lying on their side potentially.
yeah, what we've got to just consider is that could be to do with the position that they're in. You know, it looks very much like the semi-erect. They're leaning over to the left a little bit. So if the chest X-ray is taken at that angle, actually the heart is going to look like it's shifted over, but I don't think it has, because we've not got anything else. We've not got a deviated trachea. You know, we've not got anything else that suggests that. So we just bear in mind that it could be to do with the position the X-ray is taken. Okay, can we see the angles? So we're going on to D here. Can we see the angles of the diaphragm?
Yeah.
Yeah, and can you see the diaphragm? I suppose is the best question. Yeah. And again, you can see the right, if you look at this one, the right is just slightly higher than the left because of liver fat. Okay. So, Jade said it earlier, consolidation, so that could be a pneumonia or something like that. And what's happening is that consolidation, the air's not getting into that zone of the lung. Okay. What can you also see on this chest X-ray, if we're thinking about everything else that we haven't seen on any others?
The 2 white spots. Don't know if that's anything to go by, but
Yep. And then what about down here?
Tube in there.
Yeah. Does anyone have an idea what those 2 white spots might be?
Maybe.
They're not. Unless they've got a piercing on that. Yeah, so you're the ECG monitors.
Oh, okay.
So these are ECG lines down here, and what they've done for the chest X-ray is they've left the attachments on, but they've just taken the wires off. Okay. And also, if you can see carefully, there's a line going down here.
Oh,
Can you see that?
Yeah.
So what's that most likely going to be? If you think about, you know, the poorly from a chest point of view, what might they be on when they've had this chest X-ray taken? Oxygen, yeah, so it could be oxygen tubing, nasal cannula, something like that. Okay. Questions? Everyone happy with that? Can they see? I think the question is, when you look at that chest X-ray, can you tell it's not right?
Yeah.
Excellent. So once we can tell it's not right, it's then just going through that process and seeing, well, what is wrong? And even if you can't diagnose that as consolidation, you know that something's going on in the right lung. And then what can we also do to, in our respiratory assessment, to sort of clarify that? What do you do in the respiratory assessment? Yeah, auscultate. Thank you, Jade. Yeah, auscultate. So if you're auscultating, what would you hear? Potentially crackles or reduced breath sounds.
Yeah.
Okay. So consolidation. So you've got reduced translucency over the area of the lung without the associated mediastinal shift that occur in collapse. And you can get the blunting and the loss of angles, but that was a mid-zone one. Okay. These as well. Okay. Other things to think about when we're looking at chest X-rays is surgical emphysema, which is air under the skin. Pneumonectomies if they've had a lung removed, or a lobectomy if they've had a lobe of the lung removed. Rib fractures, so always looking at the ribs and following the path of the ribs. ARDS, does anyone know what ARDS is? COVID, thanks. Do you know what ARDS stands for though, Jade?
Something respiratory disease.
Acute respiratory distress syndrome.
Acute respiratory disease or adult respiratory disease, adult respiratory distress syndrome, okay? So ARDS is, and it is COVID, a lot of COVID patients develop ARDS, and you can't, there's minimal air entry in the lung, it's very white all over, but again we'll look at that next week, okay? And then cysts and bullae, so if the emphysematous, they may have bullae. Okay, has anyone got any questions?
Little one. If there is, probably, I think I know, but I don't know for sure. If there's any like tumours or anything, how will that show on a check? Will it just be an area?
It'll be like a white
spot
dot. But if we're thinking from a lung point of view, a lot of the time it's metastatic, it's mets,
Yeah.
so there'll be lots of little white dots all
Right.
over the lung.
But they'll be more sort of obvious, if that makes sense.
Oh yeah, they'll be very obvious.
Right, okay.
So everyone's happy with the A to E approach
Yeah.
and how to look at it. So every chest X-ray you would do A to E. But what do we need to remember first when we look at chest X-ray? What do we need to remember to do that we weren't able to do today?
Check the name, details of the X-ray.
Yeah, name, details, and then what? Can you remember what right was at the beginning? If we're thinking about how the X-ray has been taken.
Or if there's rotation.
Yeah. If it's AP or PA,
Position.
if it's under or overexposed, yeah, your position. Right, so what we're going to do, what I'll do is I've got some handouts for you just to go and work on, and then we're going to have a consolidational session next week if everyone's happy with that.
Yeah.
Okay. And also I will send the presentation out to you all so you've got a copy and you can have a little look in your own time. Any questions or anything else? No? If you have got any questions between now and next week, either ring me or email me or bring them to next week's session. Okay.
Thank you.